So just to introduce Zac, as you can probably see from the opening slide here, Zac is a research fellow here, coming over from Bendigo, maybe about 5 months ago now, perhaps. I'm sure Zac can tell us in a second.
Yeah, mid-Feb, yeah.
Awesome. And then, so this is our seminar series now. So yeah, thanks, Zac. We'll save obviously questions till the end and obviously use the chat function as well if you do have any questions.
Great. Perfect. Thanks, Luke. And thanks for everyone for having me for today's seminar. And apologies I couldn't make it there in person. But I appreciate everyone who's made it online, attending virtually and also on campus. So for those of you I haven't met, my name's Zac Rostron, and as Luke just said, I'm a research fellow. I started here at Bundoora early to mid-February this year. And from the title of my presentation, so from research to clinic and back again, kind of made the round loop going to work clinically after completing my PhD and back into the research fellowship position here. And I'll talk to you a little bit more in detail about that later on, but we'll get started if it lets me. There we go. Perfect. So a little bit about myself. I grew up in Bendigo, conveniently enough, about 5 minutes around the corner from the university, the Trobe University Bendigo campus. And that's where I completed all of my studies. So I've done my undergrad in exercise science, master's in exercise physiology, went into an honours in science, and then further completed my PhD in sports medicine. I've put a photo up there of one of the main kind of intersections in Bendigo. It's not a massive place. So if you have been to Bendigo or intend on visiting, this intersection just here of View Street and Mitchell Street, where the fountain is, and Roslyn Park, it's kind of the main kind of area in Bendigo, and especially where all the restaurants and food spots are. If you ever intend on visiting, that's probably where you'll go. I've also put up some photos there on the slide of La Trobe Bendigo campus. And again, if you have been or intend on going, you'll probably bump into a couple of locals there. And in that bottom photo, you can see there's kangaroos constantly moving throughout the campus. So if you're going to go grab a coffee, depending on the time of day, it doesn't necessarily matter. I've been to the SU midday and there's been kangaroos jumping around right in front of me. So just be aware of that. After finishing my PhD at Bendigo La Trobe, we moved to ACT, so Canberra, where I briefly lectured in fourth year exercise physiology, focusing on musculoskeletal rehab with a teaching focused position. From there, I moved into a corporate injury management position, where I was one of the lead exercise physiologist consultants for a third-party company that worked mainly with insurance companies, so injured workers and people that have been in quite severe accidents on the road. From there, I've got a young family. So I have two sons, Arthur, he's now 3, and William, he's 3 months old. And we wanted to kind of move back to Bendigo to be a little bit closer to family. I've got a heap of brothers and sisters and nieces and nephews, so I wanted them growing up around their cousins. And I also had the opportunity of starting work as an accredited exercise physiologist, again, focusing on the kind of my interest area, which was musculoskeletal rehabilitation. A little bit about my teaching background. So again, in 2017, I think that was around when I started my honours. I started demonstrating and facilitation work, mainly in anatomy. So in first year, gross anatomy across cohorts, and then also leading on from there over the years, took part in demonstrating more profession-based anatomy, both in second year functional anatomy and within the wet lab. And then also my brief stint at University of Canberra delivering the musculoskeletal rehabilitation unit there. From there, went back to clinical, and throughout that time, went back to clinical work when we came back to Bendigo, where I, again, had that opportunity of working within that musculoskeletal and orthopaedic rehab field, also doing a lot of kind of strength and conditioning work, body comp work with some of the like local athletes, the Bendigo Braves, the local cricket teams, things like that. From there, I was hoping to get back into academia and research. So I was able and fortunate enough and lucky enough to pick up the research fellowship position here and I started that in February of this year. And now going back, I thought I'd take some of the time today to talk to you about some of my previous research. And some of it, well, pretty much contributed to the bulk of my PhD. So I was one of the researchers that worked on the GHOST trial, which stands for Gluteal Exercise for Hip Osteoarthritis. And this was a large international randomized clinical trial that was conducted across multiple sites. So Victoria, Queensland, and New Zealand. And the aim of this clinical trial was to establish whether a targeted resistance-based exercise program would improve gluteal muscle size and function in people with hip osteoarthritis when we compared that to a sham intervention. And I'll break that down in a little bit more detail in a moment. But as part of my PhD project, I specifically wanted to look at whether this targeted resistance-based intervention or targeted resistance-based program would increase muscle size and strength in people with hip osteoarthritis. And I also wanted to see its effect on gluteal muscle activity, especially during gait within that population. So a little bit about the research background. Our clinical population was people with hip osteoarthritis. Now, if you're unfamiliar with hip osteoarthritis, and you might hear me just say hip OA again, it's just kind of ingrained in me now using that kind of abbreviation. So hip OA, it's a degenerative chronic condition. And it most typically affects the weight-bearing joints, with the primary change occurring in the articular cartilage, which again, over time can lead to pain and dysfunction. Now, I've got an example, this picture here on the slide, of someone's hip X-ray. Now, if you're, I assume everyone's sitting down now, but if you're sitting down and you kind of put your hands on your hips, just in that kind of general location, this image is slightly more distal or slightly further down from that area there. And it shows kind of a vastly decreased joint cavity on this individual's right hip when you compare it to what we would kind of, see within a relatively kind of healthy hip over this side with the kind of that joint space. Now, this condition is very common in Australia. So again, 1 in 11 Australians have some form of osteoarthritis. And it's more common in females. And again, the burden, there's above 32,000 hip replacements every year. So again, we'll speak on that in a little bit. A little bit more about the research background. What we know in this population is that muscles atrophy, which means they shrink. And we also see muscle weakness and changes in the muscle activation. Now, we see this with hip osteoarthritis, mainly within the hip stabilizer muscles, the gluteal muscles. So you might hear me just, again, refer to those as interchangeable terms going through. And you can see in this image down here, I've got an example. So we're looking at this individual from the left-hand side, and you can kind of see their left hip here. And the main muscles that I was kind of focused in on was the gluteus medius muscle, and deep to that, the gluteus minimus muscle. Okay. With previous research, we've kind of found with these muscles that we can kind of divvy them up into muscle segments. And there's kind of this term that we coined, well, that was previously coined, muscles within muscles. So these muscle segments can act independently of one another. Hence why we're kind of targeting those muscle segments and not the muscle groups as a whole. So for example, gluteus minimus, we can, again, these muscle segments are based on their location relative to the joint. So with regards to the hip joint, the gluteus minimus can be segmented into an anterior and a posterior segment. So again, you may see on the slides later and hear me say glute min A or glute min P. I'm referring to gluteus minimus anterior and gluteus minimus posterior. And the same thing for gluteus medius. We have an anterior, a middle, and a posterior segment. And again, based on the orientation of these muscle fibers and their location relative to the hip joint. going to the physical activity and rehabilitation programs at the time of this research, they were kind of aimed at reducing pain, improving muscle structure and function, yes, but there was not much evidence on the effect of these programs specifically within hip muscles and the hip osteoarthritis population. So it was quite limited. So in essence, what I wanted to kind of look at was if we train or target these muscles with a resistance-based program or a targeted resistance-based intervention, do they get larger, do they get stronger, and do they have better activation? So participants were sampled from a mild to moderate hip osteoarthritis population, and during recruitment, they would have had to have been previously diagnosed with hip osteoarthritis with a recent X-ray completed over the past 12 months. So that was part of this two-stage screening process that I completed. So in stage 1, as you can see in the flow chart, it was via the telephone. So that's where I would confirm a big long list of inclusion criteria. And again, the first thing off the bat was always confirming whether they have had that previous diagnosis of a hip osteoarthritis. And again, after that, we go to stage 2. This was a physiotherapy screen, and that's where a physiotherapist would rule out any other confounding kind of conditions, some lateral hip pain or referred lower back pain, things of that nature. So once the participants was included past the two-stage screening process, we collect baseline outcome measures. And from there, the participant was then randomized into one of 2 groups. So as I was saying before, we had this targeted intervention group, which focused more specifically on the gluteal muscles. And we had this other group, which again, you'll see me refer to it as a sham group or a sham intervention, which was more of just a typical, somewhat standard osteoarthritis rehabilitation program. So they would both run for 12 weeks, and they were both conducted at a physiotherapy clinic located in Bendigo, with one supervised exercise session per week, and that was combined with at-home exercises as well throughout that kind of 12-week intervention period. And by the 13-week mark, we would then collect the same outcome measures that we've done at baseline, and I'd use those for the studies that I'll go over in a minute. With regards to the interventions, so some of these examples of the targeted and sham intervention. So with the targeted intervention, it mainly involved weight-bearing exercises and included movements such as internal rotation whilst completing some of these weight-bearing exercises. And you can see here on the left some of the examples. So we've got a split squat here with the resistance band, kind of with that resisted internal rotation during this movement. The same thing with the staggered stance bridge here. So this was compared to the sham intervention, where this was mainly non-weight bearing exercises or exercises completed whilst sitting down or laying in a supine position. And it wasn't necessarily, these exercises weren't necessarily targeting the gluteal muscles. So the main difference between the 2 interventions was intensity associated with the exercise, the weight bearing nature, and the fact that they weren't targeting the specific gluteal muscles or muscle segments within that gluteal region. And just going through a little bit about the data collection and methods that I used. For muscle size, we used MRI, so magnetic resonance imaging. And you can see an example of one of the slices or one of the images that we use there to trace out. So to include the entire length or the entirety of the gluteal muscles, just like I was talking to you before, how I asked you to put your hands on your hips. If you can do that again, it's essentially from that region down, we would take 56 horizontal or transverse images or slices, and they were about 6 millimeters apart. And after receiving these scans, I would then go through and trace out manually all 4 muscles. So you can see on this image here on the left-hand side. So if you're unfamiliar with looking at MRI images, especially with the hip, you can imagine this image here is kind of a horizontal or transverse cross-section of, again, that area or just beneath and below that area where I asked you to put your hands on the hips. And you're essentially looking as if someone was in front of the screen now. You're looking from the feet up, or again, if you're looking at someone that's at the end of a bed, or you're looking from the feet upwards. So that's kind of the image that you're looking at there. As I said, when I get these images, I would go through and manually trace out each muscle. So you can again see an example image here. So I've got gluteus minimus, gluteus medius, gluteus maximus, and a little one up here, tensor fasciae lata or TFL. When tracing out all of these muscles, I was completely blinded, so I wouldn't know whether they were pre-test or post-test. I didn't know which was the affected or unaffected limb. And I was also blinded to whether they were within the targeted or the sham group as well too during all tracings. And here's another kind of example of one of the image from the software program that I used. So I mainly would focus on using this top left-hand image here to complete all my tracings or my masks that we would call them as well too. These other images here, I could kind of just zoom out and go into and just have a look at to make sure that the mask or the tracing of each individual muscle was all going kind of what it should look like. So for example, the gluteus maximus in this image here is shaded blue. So I could zoom out to this more 3D image down here and have a look and make sure I haven't kind of abruptly gone into gluteus medius, which was in the green kind of thing. So it kind of just drew a better picture for us when we're completing the tracings of each mask. And for muscle function, one of the measures of muscle function we used was muscle strength. And we used to collect this information, we used a handheld dynamometer, and we used that for 6 different test positions for the hip. And again, here's an example of all those test positions just on the right here. And we would ask the participant to push into a maximal voluntary contraction for 3 seconds. And we did this for a total of 2 trials. And we would start on the contralateral limb first and use the higher value, then normalize it to body weight. So we've got an example of each test position here. So we've got abduction at the hip, adduction at the hip. This would have been internal rotation, external rotation, hip flexion, and hip extension. And again, you can kind of see we had to get quite creative in terms of performing all of these strength movements or test positions going through. One of the other outcomes that we recorded was muscle activity. So to record muscle activity, we used intramuscular electromyography or intramuscular EMG. So I'll refer to it as EMG. And we've got an example of the setup just over here. Now we're looking at this individual. This is a posterolateral view. So this individual's laying on their left-hand side on a plinth, and you can kind of see here, this is their right hip after all of the EMGs have been inserted. Now, with these, with the setup on these, you can kind of see a breakdown of each individual insertion. So you can see I've kind of arbitrarily, like abruptly labeled them going through, but we've got gluteus medius anterior, the middle segment, and the posterior segment for gluteus medius, and it kind of reflects this image here. Again, I know I'm looking at the left hip, and then I've got an image of the right here, but going to the gluteus minimus anterior too, we've got anterior and posterior segment. And again, you can kind of see the anterior gluteus minimus muscle segment and the posterior gluteus minimus muscle segment there. Good. Okay, and zooming in, this is kind of the information that we're looking at. So it's kind of looking at muscle activity with regards to motor unit recruitment. This is kind of an image you can kind of imagine, draw a better picture in terms of the information that we're picking up when we're inserting these electrodes into the gluteal muscles. We're picking up that kind of electrical activity for each individual muscle fiber, and therefore giving us that that muscle activity measure for each individual muscle segment. This on the right-hand side is a comparison, another MRI image, but I've just kind of used this to demonstrate why we used intramuscular fine wire electrodes as opposed to a surface electrode. So I kind of just drew those on here. The surface electrode you can see with gluteus minimus anterior and posterior here. A surface electrode would never be able to kind of pick that information up, which is fine. Hence why we used intramuscular fine wire electrodes, which is an example of one of the electrodes being inserted into the posterior segment of gluteus minimus here. Now, I've got a funny story about this one. Again, before I was able to insert these with participants, I had to go through a big training module and gain like an in-house certificate for fine wire and deep intramuscular electrode insertion. Going through my supervisor, I had to do a heap of hours watching. I had to do a heap of hours preparing the electrodes and a heap of hours obviously just practicing. I was able to practice on chicken thighs with the skin on. So that's one of the kind of tools we used. I'd had that up on a plinth and practice the intramuscular electrode insertion. Silly me, I forgot that I had kind of left the chicken thighs in the PhD den fridge. So we had a little PhD room when I was going through, and had left the chicken thighs up the back of that for a month or so. So I can tell you right now, I wasn't the most popular person in our little PhD den for a little while after forgetting about those up there. But also, lucky enough, after I'd done enough hours on those, my supervisor at the time, my primary supervisor, Rod Green, he was the lucky first participant for me to practice on. So I think talk about a stressful situation going through as your PhD, having your primary supervisor, as your pin puppet, practicing EMG insertion. That was an interesting process, but again, all done and dusted, and I was able to then complete this with the participants coming through for the Ghost trial. And just a little bit more about kind of the gluteal muscle activity information that we used. This diagram kind of illustrates the gait cycle. So again, during walking, we'd want to have these electrodes inserted and then kind of see what these muscles were doing while someone was taking steps. So the gait cycle, if you imagine the gait cycle being from 0 to 100%, you can see at 0, if we're looking at this individual's right hip, so let's say this individual had hip osteoarthritis on their right-hand side, from heel contact, or their initial contact point for their right heel would be 0%. Going through their stance phase to toe off of their right limb, they would then be in swing phase. Sorry, toe off here. They would then be in swing phase, and their opposite or contralateral limb would then weight bear and then take us through the stride to their right heel contact again. Now, what we were primarily focused on for the Ghost trial was the first 60%. So that 60% of stance phase. Again, because during the swing phase of that right limb, their affected side, for example, again, in this image here, their right limb would then be in swing phase, and their contralateral side and the gluteal muscles on that contralateral side would then be primarily active. So we're kind of really primarily focused on that first 60% of the gait cycle during their stance phase. And you can kind of see an example of the muscle activity for a gluteus medius muscle in that stance phase compared to swing phase. Now, on the right-hand side, I've got a couple of line graphs here showing gluteus minimus muscle activity within a healthy population and a population that has hip osteoarthritis. We've got gluteus minimus anterior in red and gluteus minimus posterior in black for both graphs. And I've shaded out that first 60% of the gait cycle, so that stance phase, as you can see. And what's interesting about this is when we're looking at specifically the gluteus minimus muscle, in both populations, we still have a biphasic kind of muscle activity pattern. However, in the healthy population, these muscle segments still kind of have an independent activity. So they're still active. they're still independently active of one another, whereas within the osteoarthritis population, this kind of independent function diminishes. And we can see kind of an earlier peak, for example, for gluteus minimus anterior, and gluteus minimus posterior kind of dies off a little bit. Okay, so this is kind of where in people with hip osteoarthritis during early stance phase, the independent nature of these muscle segments or muscle rolls, they tend to become lost. And that's kind of what we're focusing on. And this affects their gluteal muscles in a way that, you know, their gluteus minimus anterior muscle acting as a stabilizer kind of later in that stance phase doesn't really occur. And what we typically see for gluteus minimus posterior acting as a stabilizer early in the gait cycle, again, that kind of diminishes. So that's kind of what we're kind of getting at with a targeted intervention. If we can kind of maybe improve these muscle activity patterns to see if they're more kind of reflective of a healthy population or someone that doesn't have hip osteoarthritis. Okay. And now going into some of the publications that came from these outcomes. So using the MRI and strength data, I wanted to see if this targeted gluteal intervention would increase gluteal muscle hypertrophy, reduce fatty infiltrate, and also improve muscle strength of gluteal muscles, specifically within that mild to moderate hip osteoarthritis population. Okay, and just some of the kind of key or main findings that I wanted to share with everyone today. So these are two bar graphs illustrating some muscle size results for gluteus minimus specifically. Okay, so we observed that there was an increase within the, so again, just orientating yourselves with the graphs. We've got the targeted intervention on the left here and the sham intervention on the right. Now I've labeled the blue as the affected limb and the red as the unaffected limb. Now, again, should have aptly named it contralateral limb, but we'll excuse that for argument's sake now. And we can look at baseline versus post-intervention. Now, we observed an increase in gluteus minimus muscle size for the targeted intervention, as you can see in the blue being the affected limb. At baseline compared to post-test, and also for the unaffected or the contralateral limb at baseline compared to post-test. We can see for the sham intervention that there was no increase in muscle volume observed, and there was no other kind of difference for gluteus medius, gluteus maximus, or tensor fascial lata. However, they had somewhat similar patterns, but again, just weren't any kind of significant results. Again, same setup. So we've got the targeted intervention here on the left and the sham intervention on the right for muscle strength. And we've seen an increase in muscle strength. So realistically, irrespective of the intervention, both groups showed a strength increase for both the affected and unaffected limb. Now, this is an example of hip abduction, but there was also strength increases for multiple other test positions when we done the strength testing. Now, however, linking back to the targeted group, I could potentially link the improvement observed in strength for hip abduction to gluteus minimus muscle hypertrophy, as gluteus minimus plays a key kind of role in hip abduction, which is one of the kind of key things we kind of looked at. So from these findings, despite seeing an increase in muscle strength across both groups, which is great, we could assume that there may have been a link to gluteus minimus muscle hypertrophy and that the gluteal muscle strength through hip abduction. However, it was interesting to note that this was one of the first studies that showed an increase in both gluteal muscle size and muscle strength from a targeted intervention within people with hip osteoarthritis. So that was kind of one of the good things to take away from that. And this was looking at the next study where I wanted to look at gluteal muscle activity during gait. So again, we wanted to see if this targeted gluteal intervention would positively change gluteal muscle activity patterns and improve gait within this population. So again, we've got a couple of line graphs here, and they illustrate kind of key outcomes that we observed within the gluteus minimus again, and specifically gluteus minimus posterior. So again, we've got the targeted intervention on the left, the sham intervention on the right, and we're looking at percentage of peak activity so the muscle activity. And we've also got the percentage of gait cycles 0 to 100, and you can see again that 60% of stance phase leading into the swing phase. So we're kind of primarily focused on this area through here. The solid line is the baseline, and the dotted line is the post-intervention. And you can see that post-intervention, the dotted line for the gluteus minimus gluteus minimus posterior muscle segment, it has a slightly higher peak in stance phase and a little bit earlier on, which, again, going back to that graph that we've seen before, is somewhat more like a normal population of a similar age. So it's kind of a good little finding, whereas we didn't see any changes within the muscle activity patterns from the sham intervention. So again, summarizing those kinds of findings, the key things we took away from that was, okay, yep, there was change in gluteus minimus muscle posterior muscle activity, which started to resemble a more similar kind of muscle activity during gait that has been previously observed in an age matched population. And interestingly, there were some other kind of little outcomes that we got from this study as well too. There was an increase in, a decrease in stride time for the affected limbs, across both interventions, and also a decrease in discomfort scores across both interventions. So that was another little interesting finding that we had going through. So with regards to kind of key findings from what we had, following the targeted gluteal intervention, these changes in gluteal activity patterns, specifically the gluteus minimus posterior segment, looking more like a kind of a normal population during gait, could potentially kind of reflect the gluteus minimus muscle volume increase, and also that improvement seen in hip abduction. And again, considering that it plays a key role in that movement, specifically, following that kind of targeted intervention, this was kind of a nice little finding that we had. And going through, this was like this. I added this picture in. Sorry, this was post conference that we delivered to osteoarthritis, the Osteoarthritis Club here in Bendigo. So I've got myself, a couple of the organisers, and my primary supervisor Rod, and co-supervisor Anita for my PhD. So that was kind of a good little thing that we were able to do after finding some of these results. So we can go deliver that to the local Osteoarthritis Club, which they appreciated. So some key kind of considerations from there. Moving forward, these were some of the first studies to show the effects of a targeted gluteal intervention on the gluteal muscle volume and strength, specifically for mild to moderate hip osteoarthritis population. So it was important to consider that rehab programs that were currently prescribed considered lower limb muscle groups in general. However, this intervention targeted key segments and targeted the specific muscle, gluteal muscles by themselves, as opposed to just kind of a whole lower limb kind of movement. So yeah, and ideally what it provided was some insight for health clinicians moving forward to the potential benefits that a targeted resistance-based exercise program could have on gluteal muscle structure and function in people with hip osteoarthritis. So hopefully that could kind of aid in their kind of the facilitation of their rehab going through. And onto my research fellowship. So I've noticed everyone putting photos of their supervisors in previous presentations. So I've fit in, and I've put Kate and Jody up there. I've been very lucky to start working with both Kate and Jody, and looking at doing some work on the anterior cruciate ligament reconstruction population. So current work. So while I've been here, and I'm still kind of sorting out future research plans, because again, it's starting mid-Feb, it's kind of still early phase where we're kind of at in terms of our development in terms of research plans. I've been working on and recently submitted a manuscript that looked at if we could identify changes in dynamic balance between two different time points, so 6 and 12 months, for people following anterior cruciate ligament reconstruction, and whether the change over time was different for these patients according to age, sex, graft type, and activity level. So what we found just briefly was there was a slight increase from 6 to 12 months, although by 6 months, most of these patients had met or surpassed previously established performance criteria, which essentially means by 6 months, they got their balance back, so it seems. And another good little finding we kind of come across was that the patient-related factors, so age, sex, graft type, and activity level, didn't have any effect on their change from 6 months to 12 months as well, too, which has previously been seen. And looking ahead, so since starting here in February, the research has been a little bit different to kind of what I've previously done. So especially coming back from working away, I've noticed going to work within the kind of the clinical setting. Obviously, we stay up to date with kind of what's, all the moving parts in terms of delivering rehab and exercise prescription and all that kind of stuff. But coming back to the university and kind of the academic research realm after a few years, it's been kind of interesting to get all the cogs and all the gears moving and firing all again. So it's been a little bit of a whirlwind the past couple of months. And not to mention, William was born a week prior to me starting the position, interestingly enough. So the dominoes fell where they fell. It's all good. It was all by design. So I'm still getting my head around some of the different kind of research questions and the population with regards to like the ACL reconstruction population. And it's been a bit of a change up for me, obviously, from the hip osteoarthritis, but it's obviously a process that I'm absolutely enjoying. But in the meantime, I've started working on another manuscript. So we're looking at group physio treatment versus individual sessions. So that's coming together as well too. We're hopefully looking to present at the upcoming iCourse conference later this year, but again, waiting to hear back regarding the submission for that. And again, pretty much still just kind of trying to find my feet with regards to future research plans. So some of my kind of research interests, obviously just within the early stages, I'm really kind of interested in muscle structure, muscle size, volume, cross-sectional area, all that kind of stuff, and how I can kind of use that to relate that within the anterior cruciate ligament reconstruction population. So again, there's going to be more to come on that front as I go through. Again, still just trying to find my feet. So yeah, plans are all in the works, but that's kind of where we're at so far, and a brief rundown of kind of what I've previously done with regards to some of my research. So I appreciate everyone for sticking around and listening, and I'm more than happy to answer any questions.